Okay, I think we'll get started while the last pizza is being taken. It is my pleasure to introduce my colleague in medical oncology, Liz Kessler. Liz got her BA at University of Colorado Boulder in she was an English major and environmental science, and you can still become an MD if you do that. She did go on to get her MD at New York Medical College before returning back here to Colorado to do her internship and residency here. And then she was one of our fellows in our fellowship program where she did research with Tom Flagg. She is now an assistant professor in our division, and she focuses on genitourinary GU, medical oncology patients. And today she is going to talk about geriatric oncology current perspectives. So I should take it away.
Does this make this like? Well, thanks for having me, and thanks to those of you who have been able to make it. I know a lot of people are out on spring break. So as mentioned, I'm a genitourinary oncologist. So I focus on cancers of the urinary tract, mainly seeing patients who have prostate cancer, bladder cancer, kidney cancer. And so the majority of my patients fall into an older age range category, and I became pretty interested in the care of older patients with cancer and if this was unique or how to approach this slightly differently. So today we'll talk through just some broad topics. We'll talk a little bit about, understanding the need for this, identifying current practice models, and then talking a little bit about some of the research which is ongoing. We know that cancer is a disease of the aging. So most patients who are diagnosed with cancer are diagnosed in the older years. And as I use this term older, some people might use the term geriatric, elderly, etc. There are different definitions on where that cutoff falls. But for the most part, many things will kind of define that as age 65 or above. And so as we're looking at patients who are age 65 and above, we know that more than half of the cancer diagnoses fall into this age range. We also know that the population is aging as a whole. And so if we have more older patients or older people, we're going to have more older cancer patients. And so we need to think about if there are unique approaches which are necessary in the care of these patients. The interesting thing is that as we look through some of this estimated cancer prevalence, you can see that this is a slide which breaks down these age distributions, and it's almost like these categories of young old, which would be 65 to 74. That category is going to change some, but not a ton. But it's the higher age groups in which we'll see some of the biggest changes. And so our older people are going to be a population which we need to really think about as that population will be growing at a much higher rate than what we're used to. And why is this population unique? Part of that is because these patients have comorbidities. So they have other medical conditions besides cancer, and they are more likely to have more of these other conditions, which are clinically important and may play a role both in their overall biology as well as the approach to care. These patients generally, as they're diagnosed with cancer, also acquire additional comorbidities. So a cancer diagnosis will only increase that burden. For example, a patient may have had one comorbidity, now suddenly they have bladder cancer, plus they have renal dysfunction because of their bladder cancer, because the tumor has blocked the flow of urine. So that's a new comorbidity that they're also dealing with. Or they've started cancer treatment, which has caused neuropathy or altered sensation, and they're dealing with that comorbidity as well. Patients also have altered organ function. So we know that as persons age, their kidney function and liver function alter or decline. And so these patients aren't able to metabolize medications in the same way as their younger counterparts might be able to. In addition, the hematopoietic reserve is altered. So if we're giving something like a cytotoxic chemotherapy, they may not be able to recover bone marrow function as rapidly as someone in a younger age category. We also know that they have decreased functional reserve, and this speaks to the fact that it's almost that buffer that you might have that allows you to recover from or absorb different health insults. For example, if I were to break my hip today, it would be a decent recovery period, et cetera, but I would likely be able to recover from that to near, the same function that I'm at now. If you think of somebody who's older, who's already pushing the limits at being able to get around independently without a walker or a cane, if they were to break their hip, go into the hospital, perhaps have a long stay in the hospital, not be able to get out of bed as much, they may have additional declines which they can't recover from because that functional reserve is at a much lower threshold. They have less of a buffer for that recovery. And so when we're thinking about some of our cancer treatment approaches, we need to think about what the functional reserve is of our patients to try to estimate their ability to absorb some of that. And then life expectancy is different. So if we have a treatment that works really well, but we see the impact of that treatment 10 years down the line, then in somebody who has limited life expectancy, we may not want to entertain that approach because it's unlikely that we see that benefit in that patient's limited lifetime. The other things to think about, besides some of those more biologic considerations, are how these patients might approach their care. So they may have different goals. Longevity may not be the primary goal, but it may. It's just important to understand that. Cost may be a consideration. Cost is a consideration, I think, for almost any cancer patient, but many patients in this population may be living on a more fixed income. They may have less ability to go out and find additional income or work. And so understanding how the burden of their treatment and the cost that's associated plays into their overall budget is a consideration. Transportation and support. Not all older patients are driving independently, and they may need to think through some of the other considerations in getting to clinic, and then cognitive associations. So, making sure that we're identifying any cognitive decline in some of these patients too. So I'll switch now. This is actually a placeholder, but it also is an interesting thing in that there's a UK program in which they have actually a whole kind of PR firm trying to raise awareness of the care of older patients with cancer. And so they've gone and interviewed different patients. But we'll switch now a little bit to talk through, how these patients have been represented thus far and what the care models are in the approach. And so there is this field called geriatric oncology. And, I think that it's kind of just arisen out of this recognition that people are aging, that cancer is a disease of the aging, and that we don't have a great deal of data to help guide how to best care for patients here. And so the International Society of Geriatric Oncology was formed here in the year 2000, and that group mainly is focused on training practitioners who might want to focus in this arena. And those are both geriatricians as well as oncologists, and there are some people who are dually trained. I think that's a minority. Most people have an interest in one or the other, but there are dually trained professionals. And then we've seen more and more kind of guidelines put forth on how do we need to think about the care of these patients differently. And some people say, well, we do clinical trials. These patients are enrolled on those trials. Can't we just use the trial data and know that that is applicable to our older patients? But the issue here is that we can't fully learn from clinical trials because the representation of this older age group is generally pretty small. And if you notice, from the year 2001 to 2011, this was enrollment on various cooperative group studies, that yellow and blue boxed area has stayed for the most part fairly stable. And so if we know that this population is increasing, then why is that staying stable? It should also be somewhat increasing, and we're not seeing that to the same degree. We also know that of many of the drugs which have been approved in recent years, that in those enrollment trials, so those pivotal phase 3 studies, a smaller number of patients in this older age group are represented. So if 33% of the patients were over age 65, but in the general population, almost double that was actually the considered population, then we know that we're only getting a small slice or a small sliver of these patients enrolled. And for the most part, those are the more fit, more healthy patients, maybe patients who live closer to academic centers. It's harder to really understand how that reflects this real-world approach. So the SEER database is a collection of data of different patients who have been treated in real-world situations. If we look at the SEER analysis, they looked at a general population of patients age 75 or older, and they looked at the outcomes of these patients in a couple key cancers compared to clinical trial results to say, well, are we seeing the same things? And what we noticed is that many of these patients received the recommended first-line therapy, but that they generally had shorter overall survival compared to the clinical trial participants. The other consideration is that many of these patients didn't go on to receive another line of therapy, so they only got the first-line therapy, whereas a lot of clinical trial participants may be more apt to go on and receive additional lines of therapy because they're at an academic center where their physicians, may consider additional lines of therapy on a broader scale. The other thing to think about is that these patients are interested in participation, but it's somewhat of a barrier. Some of those things that we've talked about before. We also know that in general, not everyone is eligible to participate in clinical trials, whether they're older or younger. The trials have pretty strict inclusion and exclusion criteria to the point where some Institute of Medicine reports have recommended trying to relax these criteria as much as possible. And it's hard because you're trying to keep your trial population safe. You're trying to really clarify the signal of whatever treatment you're offering. But at the same point in time, understanding how that applies to a real-world patients is occasionally difficult. The other thing is that clinical trial design can be complicated, so that when you give a patient a 65-page consent form that outlines the trial, understanding that trial can take hours to go through that with a patient, and sometimes patients are unwilling, and other times it's the practices that are unwilling to do that. We know that the travel can be a consideration, and then physician censoring, or this concept of age bias, is also something that comes up. So a survey of U.S. oncologists indicated that about half of them excluded patients from clinical trials with age alone as being their primary reasoning, in that they think, well, this patient's older, they're not going to go on a trial. In prostate cancer, so a disease that I'm familiar with, and also a disease in which we have a lot of data in older patients, nicely, we know that this study was reported in which the standard of care approach was radiation plus hormone therapy to be given as definitive therapy for patients with intermediate or high-grade prostate cancer. And there was an overall survival benefit seen, standard of care, but in this SEER analysis, so again, analyzing a database, so this is retrospective epidemiologic analysis of all populations, we saw that only that half of the men age 65 or above, and even higher in those age 75 or above, were offered hormone therapy alone. So they weren't offered the radiation component, and the radiation component is likely the more active treatment and the probably the larger contributor to survival benefit. Additional trials have actually shown that hormone therapy alone does not aid in survival benefit for patients. So even though there's level 1 evidence, practitioners had kind of edited the treatment assignment for patients based off of what they estimated was a better tolerated therapy for men. So if we think through care models or how to incorporate geriatric oncology into general care, because it seems to be evident that the trials aren't always enrolling patients to give us data to help, and that there is probably a large community of oncologists who aren't as comfortable taking care of older patients or offering them maybe standard of care. What are some models in which we can think through the approach to care of older patients? And so we think through this geriatric oncology iceberg. This is a slide which I've borrowed from our colleagues at UNC. They have a large geriatric oncology program there, and they'll talk through things that many oncologists are familiar with. We consider age, it is a consideration, partly because we know that organ function might be different, hematopoietic reserve, et cetera. We think through performance status for almost any patient we're offering treatment to. How able are you to carry out your daily activities? We definitely consider tumor characteristics. So tumor biology is going to play a role in any treatment we offer, as well as how well organs are functioning. But there's this entire under the surface approach too, which I would often argue shouldn't be only assigned to the care of older patients. It's the way many practitioners care for patients in general, but these may carry higher weight in older patients. So I don't care as much if my 26-year-old patient with testicular cancer has fallen recently, but that may be a larger indicator of further morbidity or mortality in an older patient population. And so we need to think through many of these other approaches and understanding which of our patients are going to be fit, robust, meaning able to tolerate therapy without alteration, which patients are going to fall into this middle range, which is called vulnerable. And that's where most people fall. That means maybe their nutrition isn't perfect, maybe they take a couple extra medications, but we could probably tweak that and still offer them therapy to their cancer without a great deal of harm. So the benefits would likely outweigh the harm with some tweaking. And then there's this category of frail, and there are different definitions of frailty within the geriatric literature, but these frail patients are the ones that are more likely to have irreparable harm or harm from their therapy that would be very difficult to recover from. And those are the patients that we really want to be able to identify in order to not embark upon a treatment that may be harmful. In addition, we don't maybe want to alter therapy that could have excellent disease-specific outcomes solely based off of an age assignment if our patients are otherwise fit and robust and able to tolerate it. The graph below is basically just a life expectancy calculator. So the y-axis is years of life expectancy, the x-axis is that patient's age, and the differences there are that the middle bars represent those with average health. The bars to the left are those with excellent health, and the bars to the right are those with probably multiple other comorbid conditions or worse health. And what you can notice is that an 85-year-old with average health has an estimated 7-year life expectancy, an 80-year-old, but an 85-year-old with excellent health has actually a little bit longer life expectancy than somebody 5 years younger. And so really kind of understanding how all of these pieces fit together is helpful as we create this care plan. So there is kind of a standardized approach which has been put forth. This was Marjorie Warren, she's a nurse in the UK who decades ago came up with this concept of the geriatric assessment in which you use validated tools to assess a patient's status within these different categories. And a geriatric assessment takes a really long time. It takes hours to go through a validated nutritional questionnaire, a validated assessment of function, etc. But there are situations and clinics that do perform a geriatric assessment. Here at the University of Colorado, our geriatric or seniors clinic doesn't generally perform a comprehensive geriatric assessment on all their patients, but they do utilize portions of it or screening portions to identify those patients that may benefit from a bigger assessment or a more in-depth dive. The impact of the CGA has been shown to, help with improved care planning, better use of supportive services. We're just trying now to better understand how it might impact overall disease-specific and patient-specific outcomes. But it is recommended by many societies in clinical oncology, the National Cancer Comprehensive Care Network, et cetera. And each of those recommendations is a little bit different. So the NCCN says do this for patients over 70. SIOG says do this for patients over 65. ASCO says do this for older patients. And the do this is different. So they don't recommend one assessment over another. They don't recommend one screening tool over another. So the general sense in the field is that there is some benefit to be seen by assessing our older patients. There are validated tools to do that. But the approach hasn't been streamlined or standardized across the field of oncology. There are other tools to help assess the risk of chemotherapy toxicity. So I think this is an area where many people get nervous as we offer chemotherapy to older patients. but our patients are generally older, and chemotherapy is still one of our most common treatments. What we need to think about is how that therapeutic window fits if patients do have altered metabolism or other considerations. And so there are two tools, the CRASH tool and the CARG tool, which have been validated to predict for grade 3 or 5, which are the more severe chemotherapy-associated toxicities. And this question of should we give older patients chemotherapy comes up because we know that the risk of chemotherapy toxicity can increase with age because organ function is different, functional status is different. But we also know that older patients seem to benefit just as much as younger patients from that chemotherapy treatment. So there are various studies showing that they can still have a similar response rate to chemotherapy, similar disease-specific outcomes if they're offered chemotherapy. And so while there is a risk of toxicity, there is also that same potential promise of benefit. We also know that older patients are less likely to be offered chemotherapy based off of these concerns of tolerability, or that they're more likely to be offered kind of baseline dose alteration. So an oncologist may say, I have this sense that you're not going to do as well on treatment, so I'm going to reduce your chemotherapy by 20%, 25%, whatever that estimate might be, without a lot of objective guidance in that decision making. But the main guidance would be chronologic age and likely some measure of performance status. There was a survey sent out to members of the American Society of Clinical Oncology in looking at what are some of these major areas that we should focus on within geriatric oncology. And they were split into research, treatment, and education. And in the research category, most respondents said we need to understand toxicity better. So we need to have an improved understanding of how tolerable our therapies are for patients. Interestingly, there wasn't as much interest in basic science or what I spent some time on in the beginning in terms of barriers to clinical research participation. But there was the sense that we need a better understanding of toxicity, likely so that when we're talking to patients about the risks and benefits of treatment, we can actually have some data to go from. So can a geriatric assessment predict chemotherapy toxicity? Well, I've already told you it probably can because there's two tools, but this is how one of those tools was developed. So there were about 500 patients enrolled who were initiating chemotherapy. They were all age 65 or older, and these patients were assessed for toxicity at standardized visit time points. And so they did a pre-chemo assessment, a post-chemo assessment, and then had toxicity collection along the way. And the risk factors for grade 3 to 5 toxicity, so again, the more significant, generally something that we have to do for these patients, toxicities were age. So age still shuffled out, but it was age 72 or older. The type of tumor, the type of treatment. So GI, GU cancers seem to hold a higher risk, as well as patients who are receiving unaltered doses or multiple doses together. So there will be regimens that are just one chemo agent versus a combination. We also saw that there were different laboratory values which played out. So hemoglobin, likely coming to that kind of bone marrow reserve concept, as well as renal function. And then there were still some geriatric assessment variables which were predictive of toxicity as well. So this kind of shows that combination of what oncologists have been used to doing all along, combined with maybe what the geriatric assessment might be able to offer too. And so this tool was used to say, well, is it better than the general approach, which is a performance status measure that we use that's often patient self-reported. And so the KPS is the Karnofsky Performance Status Index. And this seemed to have a better ability to discriminate for these toxicities and compared to the KPS. And we've seen that in other studies in that as patients age, our ECOG performance status measures or the KPS measure just isn't as sensitive in these older patients to understand some of these other risk factors for toxicity. And so this is a tool which practitioners can go online and plug in these various values for their patient, get a printout that shows us what's the potential risk of a grade 3 to 5 toxicity for patients. It's kind of hard to use. It takes additional time. And I'll tell you as a GU medical oncologist that I get really annoyed seeing that most of my patients are going to have a high risk of toxicity because of the fact that GI or GU cancers just kind of already increase the risk. But I still do it for those patients that I feel might be in that vulnerable to frail range, and I want to have a better understanding about really what is their risk. Do I need to alter their dose? What might we need to be thinking about here? But I will say that rarely do I see trying to switch the overall regimen. I think this is an area that is ripe for research in geriatric oncology, but this is an example of a breast cancer population in which there was a prospective study performed. Patients were older and enrolled with breast cancer, randomized to receive a standard chemotherapy regimen versus something that was thought of as more tolerable, less toxic. And you'll see that the outcomes were better for the standardized approach. So they had improved overall survival if they received the unaltered approach, but also that there were 2 toxic deaths in the capecitabine arm. So the arm that was supposed to be less toxic, there were actually 2 associated deaths there. And so I think there is a need here for additional prospective work to better understand really how we are helping or harming our patients. So as we think through how people might approach the care of an older patient, we know that this is an important population to think about. There are some unique considerations. There may be some tools to better assess, and that it's not a one-size-all approach. So at different centers across the world, there are either inpatient services which offer assessment and consultation. There may be outpatient geriatric oncology clinics. Here, oftentimes, it's a referral to the seniors clinic for additional assessment. There are some geriatric oncologists, so dually trained providers who offer this input. And then there are, in some places, multidisciplinary tumor boards. I mean, here at University of Colorado, we have many tumor boards in which radiation oncologists, surgical oncologists, medical oncologists, additional experts within cancer care meet together to talk about a treatment care plan for a patient. And in other places, the inclusion of a geriatric practitioner who's also had a chance to meet with patients may also tailor that treatment plan discussion. So shifting a little bit now, we'll talk more about what research is being done in this field. We talked so far about just this as a general clinical approach, but I do think that this is an entire field that's open to very broad research. And so in prostate cancer, a cancer that I see and care much about, we know that there is very diverse disease biology. So I'm sure many of you have heard different things about prostate cancer. It's a cancer that people can live decades with. Oh, wait, I know somebody who died of prostate cancer. Wait, isn't everybody going to have prostate cancer? So we know that there's different biology, and so that we have to kind of understand really how the disease biology plays into some of these other factors. The location of prostate cancer may also impact organ function and be of significance in older patients. So I have many patients who have presented with urinary retention and failure based off of the fact of a tumor growing within the prostate, which blocks outflow of urine. We also know that patients with prostate cancer that are undergoing treatment may be on treatment for a long time. So even with advanced stage disease, they could be undergoing treatment for years. And so as we plan the care, we need to think about how this impacts overall longevity or their ability to live independently through that time. And that the primary treatment for advanced disease centers around a reduction in testosterone level. This reduction in testosterone can decrease strength, affect cognition, and have many other impacts which can be seen to a greater degree in older patients. On the converse, in a general aging population, there's a lot of research done on could we improve some of the aspects of aging by offering supplemental testosterone. And so here in cancer treatment, we're actually doing the opposite for patients. So we consider both age and disease together. If you look here at this slide, it's kind of small, I know, but this is age at diagnosis in years, and these are broken into groups here, 60 to 64, 65 to 69, 70 to 74. And then you'll notice each row represents a different Gleason score. The Gleason score is kind of a measure of more differentiated, well or poorly differentiated cancer. And so the lower rows are going to represent the more poorly differentiated cancer. And then those rows over the column to the right is going to represent the older patients. The darker gray represents prostate cancer mortality. Lighter gray represents mortality secondary to non-prostate cancer causes. And then the white area is those patients whom are surviving. And so as you'll notice that in this age group, it's actually that the non-prostate cancer mortality is of more importance than the prostate cancer mortality. As the grade goes up, certainly the disease biology comes into play. And if you notice in this direction, we see that as age increases, we may actually see that the sliver of non-prostate cancer mortality also increases, so that we're constantly seeing this interplay. We also need to understand that many of these patients have additional comorbid conditions, as I've mentioned multiple times. But in this study, they looked back at a radiation oncology trial. This was a prospective trial which was performed looking at the addition of hormone therapy to radiation therapy. A little bit different than the one I referenced earlier, but similar concept. And then they did a post hoc analysis, so we have to be wary that this wasn't their intention at the outset. But what they did note is that when they looked at the total study cohort, that radiation therapy and androgen deprivation therapy seem to improve outcomes for patients in comparison to radiation therapy alone. I know that it doesn't look like that, but the curves do separate over here. But if we look then at these patients who have more comorbid conditions or comorbid conditions which were clinically impactful for them, that we actually find that the radiation therapy alone may be a better option than the combination, and that here patients seem to do worse when they were offered the combination as compared to those with minimal or no comorbidities, which speaks to the fact that we need to take into account the entire patient when we're creating the treatment plan, especially as many of our patients are in these older age groups. Luckily, in prostate cancer, we have a lot of data of studies which have included patients in older populations. And so if you notice in many of these journal titles, these are age 75 and older, elderly patients. This is octogenarians receiving chemotherapy. And so we have done a reasonable job of enrolling older patients onto our trials. And it may be because the treatments are generally hormonal therapies, and I think that there's less concern about those treatments and offering them to older patients. But it's still a population that likely doesn't represent the true general population. So one area of my own interest is the impact of cancer treatment on physical function, and have done some work in prostate cancer, and am interested in additional cancers such as bladder cancer, in which we give chemotherapy, and understanding that the baseline physical function does predict for tolerance of treatment, and that each treatment may impact function in a different way. And for older patients that, for the most part, want to remain as independent as possible, we don't want our treatment to necessarily alter or take away that independence. So I'd hate for one of my patients to be able to live in their home independently and then suddenly require nursing home care based off of their cancer treatment. So each of these men are 80 years old. One man, requires a prop to walk with. He's a little bit hunched. It doesn't look like it's as easy for him to ambulate as this gentleman who just completed an Ironman triathlon. So same age, but very physiologically different. So we know that there are exercise studies in older populations, and that there are a majority of cancer survivors who report unmet physical needs, meaning they're not likely meeting the standards which are set out by different agencies, and that there's not a lot of data within this. So if we look up a PubMed search of physical activity or exercise in older patients with cancer, there's not very many papers that come up. And then we also need to think about each person's scientific interest. So there is a difference between maybe physical activity or exercise, so something that you're doing above your standard approach. Physical function, which is mainly your ability to carry out your day-to-day activities, and then sedentary time, which is almost a converse there, and that's time spent not moving, which we know that each one of these categories can impact general health in different ways. Each one of those categories may impact the risk for cancer development, cancer recurrence, and there's a growing body of literature studying how do these impact cancer outcomes for those patients that do have cancer. And then if we think through this in an older population, what I alluded to before is that patients are really worried about how treatment is going to impact their physical function or their ability to get around independently. And it's one of the greatest predictors for distress in older patients. And so that they might be worried about cancer treatment mostly because of this particular section. So they may be less worried about the neuropathy or low blood counts, and they're really worried about, am I going to be able to take care of myself? And then as we look through that same survey of oncologists, when they look at this patient care arena, their main goal here, one of their primary priorities, is the integration of functional status into patient care. So how can we better integrate assessing functional status or keeping this in mind in our older population? In prostate cancer patients, ADT is the treatment we use, which lowers testosterone. This is also something that lowers in general as patients age, and this can create this pattern of sarcopenia or loss of lean body mass, increase of fat mass, which can reduce muscle power, cause weakness, fatigue, or impaired mobility, and create a cycle of people who just don't want to move as much. And so if our treatment is doing this and the aging process is doing this, we need to better understand how to support patients. So there was a cross-sectional study done in patients who had been on hormone therapy, and what they saw is that those patients who had been on hormone therapy, this yellow line, that many of them, this was basically how far they could walk in a set amount of time. So the patients on treatment can't walk very far in that set amount of time, and they also don't seem to improve over time. Whereas other prostate cancer controls, the blue line, they kind of figure out the test, they get better over time. So those are men with a cancer diagnosis, but not on this treatment. And then the red line are the healthy controls. So understanding that the therapy likely impacts physical function, we did a pilot study here to understand more about the longitudinal change within the physical function, as well as maybe some of the changes in overall geriatric health. And so we enrolled 17 patients so far, age 65 or older. Most of those patients had metastatic disease, and they were initiating hormone therapy. And so they had a quality of life assessment, geriatric screening, physical testing, and a measure of power and body composition. We reassessed at 3 months, 6 months, and then 12 months. And many of these patients had a baseline alteration of the VES 13, which a score greater than 3. So the VES 13 is a screening tool. It's a geriatric screening tool, kind of like the precursor to the CGA, which identified patients in this vulnerable range. So if we think about that yellow arrow, those are the patients that might need some tweaking. We know that patients who have a score of 3 or higher are at risk for decline over time, and they may even be at a higher risk of death as well. We did see that many of these patients had an improvement in their VES at a 3-month time point, suggesting that perhaps the cancer itself was altering their overall global health, and that by treating the cancer they had some improvement. But of the 10 patients that were followed at least 6 months, half of those patients ended up eventually showing some decline. And this is pretty early data right now. We also looked at mobility, so we did an in-office test of mobility and balance, asked patients to rise from a chair, asked them to kind of balance on their feet in different positions, as well as do a gait speed analysis. And that many patients had normal mobility at baseline, but many also did show impairment. And that at the 3-month time point, 7 of those 17 patients did show a decline. And most of that decline was seen in the chair rise portion. So patients had still the same gait speed, which we know is a predictor of outcomes in older patients, still able to do some of the other balance, but they really had an impact in some of that muscle power, suggesting that the lowering of testosterone caused some of that muscle weakness, and that perhaps over time we'll see some of these longer-term changes in gait speed and such. So physical function is not the only indicator of geriatric health. We saw patients who had some impairment on mobility, but we saw more that had just general geriatric health impairment. We also saw that there could be some changes seen even within 3 months of prostate cancer therapy, and that indicates we might want to offer these patients early rehab before we see some of these changes, or even prehab, and that if cancer is treated, occasionally we can see some improvements in geriatric health as well, so that some of our patients receive some palliative benefit from treatment as well. There's a group of different researchers in aging and exercise who are put together through the Cancer and Aging Research Group and an NCI-funded U13 conference, and they have kind of met to identify different needs within this area of exercise testing or functional testing within older patients in oncology. And basically, making sure that we're choosing the right patients. There's a lot of information in breast and prostate cancer, but less so in some of our other very common cancers. Most trials exclude patients who need a cane to ambulate or a walker. They exclude patients who already are having trouble, but if you're really looking to see what the change is, you could consider including them. And that the outcomes are different. So they might mainly focus on exercise with less of a focus on function, or less of a focus on additional aspects of function. And there's no biologic pathway analysis, so we're not really doing a great job of getting other biomarkers, et cetera. Additional prospective work that's being done, and I'll go through this fairly quickly, just to kind of show that this is a broad field. The ASCO plenary session this last year actually included a focus on older patients, so patients with glioblastoma, and where there was a treatment which was shown to be effective. The original trial had excluded older patients. This trial was focused in that population, and again showed a benefit to them. In heme malignancies, we've seen that in AML, which is a very common condition in older patients, but a tricky one to treat because of some of the toxicities, there are increasing research approaches there. This is a French study in which patients were offered maintenance androgen therapy after their additional chemotherapy. And so these patients had fairly good response, and then with maintenance therapy seemed to have improved survival with that. We've also seen some benefit of sorafenib in older patients treated with AML that have FLT3 mutations. So again, trials focused solely on these older patients. This is that androgen addition trial. In addition, in lung cancer, there was a study which was a prospective trial. In this trial, randomized patients, and they were either assigned treatment based off of their performance status assessment, so clinicians could assess performance status based off of that ECOG or KPS and age, or they underwent a comprehensive geriatric assessment. And based off of their frailty assessments in those two realms, they were offered either a carboplatin doublet, which would be a fairly standard first-line choice, docetaxel if they were identified to be somewhat at risk of treatment toxicity, or best supportive care. And the best supportive care was only offered in those patients who were identified in that frail category based off of a geriatric assessment. And what we saw was that there wasn't a lot of difference in time to failure-free survival between the groups, maybe slightly less toxicity in all grades, but really no difference in high-grade toxicity. But there were also a good number of patients who weren't offered therapy at all, and there were a higher number of patients in the CGA group who were offered the doublet in comparison to the performance status assessment. And so, I think here the prospective analysis of how the CGA really added to this assessment is still to be teased out, but it did show that you could choose therapy based off of a CGA. It did show that that even though we had entire populations who weren't offered any therapy at all, the overall survival didn't seem to change in those groups when looked at as a whole. And so it is an approach to be looked at. There's also a huge area of research in terms of perioperative analysis. And so surgeons are always trying to understand what's the risk of readmission or mortality, postoperatively morbidity, and more I'm seeing different studies in which they're doing basic geriatric screens, whether this be the VES13 that we had mentioned, or sometimes even a simple chair rise, and seeing that those may even be predictive of postoperative outcomes as well. Another area that I think is of interest in oncology, and certainly of interest as we think about this older population, is that of immunotherapy. So, when we think about the fact that a 91-year-old was treated with immunotherapy and had a reasonable response, it opens a lot of questions in how do we take care of our other older patients. And in abstract, sorry, I don't have the reference here, but this abstract was presented at ASCO last year, and Memorial Sloan Kettering published on their experience of older patients, 95 of them, who were aged 80 to 93 and who had received various immunotherapy agents. And what they noticed is that most of them had similar benefits as seen in many of the phase 3 studies for these drugs. They perhaps had some higher immune-related adverse events than were reported in those studies, and some higher early discontinuations due to toxicity. So I think that this points out that we can see some activity in the disease, but again, we need to better understand how to predict those patients that may be fit to receive this. The other thing to think through is this interface of aging and immunity. Just as we do with cytotoxic therapy, think through how organ function may impact our therapeutic window. Here it's thinking about how does the general process of aging impact the ability of us to call upon T cells to reactivate and help in this anti-tumor response. And so this is an area of prospective research in geriatric oncology as well. So future directions, incorporation of a geriatric assessment more broadly, elder-specific clinical trials, looking at different therapeutic approaches. There's definitely more research to try to incorporate biomarkers to predict response in older patients, immunotherapy, as well as a large area of research surrounding how to properly train clinicians in understanding that there are different approaches to the care of older patients with cancer. And here in the Cancer Center, part of my research is working on gathering additional performance battery data in older patients in the clinic. So that's that chair rise, walking speed, validated assessment. There's also different collaborations which are occurring with both physical and occupational therapists, both at our North and South campuses, to gather additional data there, as well as some registry data. And then plans for accelerometry assessment or assessment of some of this activity, function, and sedentary time for patients undergoing additional treatments like chemotherapy. So that's the end. Thank you so much. Anybody have any questions? Yeah.
Do you feel like in your training you were prepared for dealing with these geriatric issues? And not all oncologists will want to do like a second fellowship in geriatrics.
Yeah. So I think that that's a good question in terms of understanding the training that oncologists go through. I think in general, oncologists are fairly aware of, assessing life expectancy, thinking through how performance status is important. But I think there is a little bit less of this knowledge about the resources which are available, or how we might improve the sensitivity in some of these assessments compared to that general physician gestalt. And so I think that I was fairly well prepared, but that I wasn't as aware of some of these other resources, and that's an effort which is being led by ASCO. So there are now online modules for training. I think that, here now I give a geriatric oncology lecture to the fellows, and that it is something that's being incorporated more and more into education, and that we're trying to better assess how to do that, because there was even a paper kind of surveying program directors of different oncology programs to understand who's doing what already. So, yeah. All right, thank you.